Hi, this is Dr. Len Calabrese. I'm a professor of medicine here at the Cleveland Clinic Lerner College of Medicine and the director of the R.J. Fazenmeyer Center for Clinical Immunology here at the Cleveland Clinic. In this presentation, I will be discussing efficacy of Tofacitinib by background methotrexate dose in patients with psoriatic arthritis, a post-hoc analysis of pooled data from 2 phase 3 trials by Kivitz and colleagues. This was recently presented at EULAR 18 in Amsterdam, which I recently returned from. It was a really great meeting, and psoriatic arthritis was a prime topic at this meeting. So let me summarize for you first, and I'll tell you that in patients with psoriatic arthritis, the efficacy of Tofacitinib was greater than placebo and really didn't differ when evaluated by background methotrexate dose. And the dose here, and we'll come back to this several times, less than 15 or greater than 15 milligrams per week. So that's the pivot point. You can question how it was derived, but that is the pivot point of this study. These findings are consistent with results of similar analysis of Tofacitinib in patients with RA. The importance of this is that several treatments are available for the treatment of patients with PSA. In some cases, it's unclear if the sequence of treatment affects a patient's outcomes. This study demonstrates, as best as possible, is that the initial treatment with methotrexate does not affect patient response to Tofa. So let's take a deep dive into the methods of this. So this study is a post-hoc analysis of pooled data from 2 phase 3 randomized, double-blinded, placebo-controlled studies of Tofacitinib in patients with active PSA. To get in, you had to have greater than 3 tender and/or swollen joints. In one study, patients were TNF inhibitor naive and had inadequate response to 1 or more conventional synthetic DMARDs. In the other study, patients had to be an inadequate responder to 1 or more TNF inhibitors. So different substrates going into the study. All patients were randomized to Tofa, 5 or 10 milligrams twice daily, or placebo, and there was an adalimumab comparator arm, 40 milligrams every 2 weeks. All patients received stable doses of 1 conventional synthetic DMARD as background therapy. The maximum dose of methotrexate was 20 milligrams a week, which is of note as well. So the key findings of this study is that a total of 556 patients who have received Tofa plus methotrexate only, or placebo plus methotrexate only, were included in the study. 2/3 of the patients were treated with background methotrexate, that's less than 15 milligrams, mean dose about 12.6, so low by rheumatology standards. The other 1/3 were on higher dose, mean methotrexate dose of 19.8. At month 3, both Tofacitinib doses, 5 milligrams and 10 milligrams twice daily, were associated with numerically greater improvements in ACR scores, as well as the HAQ-DI, as well as greater changes from baseline in the HAQ-DI score compared with placebo. The magnitude of Tofacitinib effects on efficacy outcomes were broadly similar in patients with background methotrexate doses below 15 milligrams compared to those in the 15 to 20 milligrams per week. In patients treated with Tofacitinib 5 milligrams daily, an ACR 20 response was observed in 47% treated with methotrexate at doses less than 15, compared with 51% treated with methotrexate greater than 15. For patients in the 10 milligram limb, an ACR response was observed in 55% versus 52% of these 2 dosing limbs of methotrexate. In patients treated with Tofacitinib 5 milligrams twice daily, a decrease of greater than 0.35 in the HAQ-DI response was observed in 48% of patients on methotrexate less than 15, compared with 56% of patients treated with methotrexate above 15. For patients treated with Tofacitinib 10 milligrams twice daily, a decrease of greater than 0.35 in the HAQ-DI response rate was observed in 52 versus 43%, respectively, of these 2 methotrexate arms. So let me kind of break this down, at least the way I think about this study. You know, we have patients with psoriatic arthritis who are candidates for advancing therapy. Small molecules are now a viable option. We can triage patients in our mind as to those that are of poor prognosis, a better prognosis, who have low disease activity, who have high disease activity. We have a lot of biomarkers. One of the things we consider is background methotrexate dose. You know, are the patients on greater than 15 milligrams, are they not going to be as robust responders as those on less methotrexate? It's a valid question. The study shows quite clearly that at least within the confines of this dosing range and this breakdown, less than 15 and greater than 15, this is not a variable that warrants clinical concern. This encourages me to use this drug in patients on methotrexate regardless of the dose, and does not change my practice at the present time.